cured, and new medications have come into market which are both highly effective and significantly easier to take than previous treatments. This piece is really important when working with people who inject drugs who may be injecting for a long time or have had their hepatitis for a long time, because previous medications were incredibly difficult to take, incredibly hard on the body and liver, and there's a lot of misinformation out there amongst people who inject drugs around the quality and availability of treatment, and it's something that we're hoping to change and make sure that folks know that no, this is something that can be cured, and it's a lot easier than back when all we had was interferon. When we're talking about Hep C transmission, we're looking at injection drug use, neophytic injuries, birth to an HCV-infected mother, some sexual transmission, and the sharing of personal items. Hepatitis C is a bloodborne infection. It's incredibly hardy, which makes it much easier to spread in the open air than HIV. However, really, the vast majority of new cases of hepatitis C, we're talking about injection drug use, and in some ways, acute hepatitis C and increases in diagnosis of hepatitis C can be seen as a proxy for an indicator for injection drug use in the community. Specifically with PWID, we're talking about the sharing of needles and syringes, but also the sharing of other injection equipment, cookers, cottons, waters, ties, and alcohol swabs, and environmental transmission, and contamination of injection equipment. This is distinct in some ways from HIV, which is a lot more difficult to spread with the secondary equipment used in injection. But with hepatitis C, it becomes increasingly important that we're not just providing needles and syringes when doing our syringe services programming or seeking to reduce transmission risks with PWID, but that we make sure folks understand that any of these equipment can spread HCV. And in recent years, HCV trends, rates of acute HCV are increasing, 350% increase between 2010 and 2014, and really amongst Appalachian states, a really rapid increase of hepatitis C amongst folks under the age of 30, and this rate was almost twice that in rural communities than urban ones, and in those cases, 73% reported at least some risk exposure related to injection drug use. These hepatitis C risk and new cases tracks really well with the rates of fatal overdose, and that's because this is essentially coming from injection drug use. In 2015, of the roughly 1,500 cases of acute HCV reported, 53% or 52% were among PWID, and 949 cases reported at least one risk behavior associated with, of the cases, rather, that associated risk behavior. Almost 80% indicated injection drug use as one of the reported risk factors. That's not necessarily the only risk factor, but in a significant majority of cases that there was a risk factor reported, injection drug use was one of the risk factors. And the role of in syringe services programs and the need for HCV prevention among PWID is highlighted in the National Viral Hepatitis Action Plan. An integrated approach to serving PWID that begins with preventing new infections and referral to drug treatment and continues through HCV screening, linkage care, and treatment is essential. Persons who continue to inject drugs, ongoing effort is needed to provide prevention services, access to drug treatment, and regular screening to detect infection. We're really looking to promote a comprehensive approach to drug user health with hepatitis C. However, it's important to remember that SSPs still serve an absolutely critical role in Hep C prevention amongst PWID. The use of sterile injection equipment at every injection incident is the best way to prevent Hep C transmission amongst PWID, but we need more than that. This integrated approach must include HCV treatment and also medication-assisted treatment, and syringe service programs represent an excellent platform from which to reach people who inject drugs and link them to these services. So we envision with the CDC a comprehensive SSP program that's part of a system of service delivery for people who use drugs, right? And that this SSP ideally is integrated directly into these other service delivery platforms, whether that's testing and linkage to care and even hepatitis C treatment being offered out of syringe services programs, or the provision of MAT directly out of a syringe service program. But at the very least, SSPs need to be seen as an integral part of the expansion of MAT in jurisdictions, for example. Due to the highly stigmatized nature of substance use and the vulnerability of people who use drugs, SSPs serve a critical role in reaching this population in a way that mainstream health, mental health, and social services providers cannot. Syringe services programs in this country have largely sprung up as an alternative health care system for people who inject drugs, in large part because mainstream systems haven't been able to serve them. And so as the opiate crisis and the overdose crisis continue to grow, and the need to reach these populations becomes more and more apparent, we need to integrate SSPs into mainstream healthcare, but also acknowledge their unique role in reaching this population and the role that CBOs, community-based organizations, harm reduction programs run by community can play as your best outreach platforms and engagement platforms for people who inject drugs. SSPs engage high-risk PWID, work to keep them healthy and connected to system of care, and provide a gateway to treatment and recovery. SSPs are the safety net for people who inject drugs. And when people who inject drugs are engaged in these other systems of care, ultimately it's SSPs who will serve as the programs that catch and maintain folks in those systems, and you should be seen as integral partners to the service delivery of primary medical care, mental health care, substance use treatment, and in all of the above. For an extremely long time, SSPs in this country, above and below ground, have been serving as effective HIV and Hep C prevention interventions. But they're much more than this. By offering non-judgmental services, low barrier and non-coercive services, they provide a critical link to broader systems of care. And they also maintain a connection with folks who often lead chaotic lives and can be difficult to reach. The idea that PWID can be lost to care in mainstream healthcare systems becomes much easier to navigate when you have community-based organizations who are offering a low barrier entry for an individual to re-engage and to follow folks between these systems. And I want to stress again that syringe service programs can often be an excellent platform to directly deliver some of these services, particularly when we're looking at medication-assisted treatment like buprenorphine, when we're looking at offering in-community healthcare and health screenings. There's no reason that a syringe services program, whether it's a mobile unit or a program run out of a fixed site, why you can't offer these services directly out of those systems. We don't need to see SSPs as being separate from these mainstream programs or these healthcare delivery systems. Obviously, a syringe services program will distribute safer injection supplies. They'll provide harm reduction counseling and education, the distribution of safer sex supplies, naloxone to reverse opioid overdoses, as well as screening for HIV, viral hepatitis, STDs, and TB. They can do referral and linkage to care, whether that's for treatment or vaccinations for hepatitis A and B. But they also offer comprehensive distribution of safer injection supplies. They're not just providing the syringes, but they should be providing all of the equipment that, as I mentioned before, can spread the hepatitis C virus, as well as other viral infections, bacterial infections. They're going to be doing both rapid antibody testing, but they can also be helping to provide confirmatory testing, either directly or through a partnership. Really focusing on the linkage part to referral and linkage to hepatitis C treatment and MAT. So typically be offering syringes in 25, 27, 28 gauge, various lengths and widths to meet the needs of folks who are injecting a variety of substances in a variety of ways. And when you're looking to imagine how you'll stack a program, it's important to have a broad and long view for what types of supplies some folks might need, but it's also important to remember all of the injection equipment a program might offer. And when we're looking at some of the recent legalizations of syringe service programs in a variety of states, you see a struggle to find money that can go directly to the purchase of these supplies. And so while it's great to see SSPs coming above ground in some places, and it's wonderful that health departments and private funders may be able to support the staffing and physical outreach materials, the vans, the sites needed to run an SSP. The syringe is still the opening offer, and all of this equipment is what leads to an SSP being able to provide that engagement and linkage platform. SSPs also tend to offer additional supplies, whether that's naloxone and Narcan and overdose prevention education and materials. SSPs are one of the best ways to get overdose prevention medication into the hands of the people who need it most, people who use drugs themselves, their communities, and their friends and family. They'll provide powdered and absorbic acid, gauze pads, Band-Aids, antibacterial ointment, bleach kits, packs and sharps containers, and other safer drug use supplies. They also commonly offer condoms and lubricant, safer sex supplies, information materials, referrals to a variety of services, warm and cold weather clothes. Often individuals who have need to access syringe services programming are folks who are unstably housed or who are homeless, and SSPs are in many ways de facto homelessness outreach programs. And all of this is part of why SSPs have access to this population in ways that a walk-in medical clinic or a primary care provider never could. And it's important to remember that SSPs provide an incredible number of badly needed resources to a vulnerable population, and that all of these things are important to keeping PWID healthy and safe. And it's worth mentioning that syringe service program models that restrict artificially the number of syringes a program can distribute have no demonstrated public health benefit and are actually harmful to participants. So for jurisdictions looking to start or expand syringe services programming, absent any legislative restriction on program models, there's absolutely no reason to enforce things like one-for-one syringe distribution. There's no evidence base for it. SSPs don't increase the number of improperly discarded syringes in community. SSPs don't increase drug use. The only thing that restrictions like this do are increase the likelihood of participants in an SSP becoming infected with a variety of diseases, viral and bacterial. Often SSPs offer, and it's important that SSPs be viewed as a place to offer a variety of medical and healthcare services, including a platform for community health workers and linkage to care navigation services, but also direct medical case management services, insurance benefits navigation services, treatment adherence specialists, and again, with the availability of office-based buprenorphine, SSPs can directly offer medication-assisted treatment if they're integrated into the systems of behavioral health. They are also an effective platform to offer social services. We know that individuals who engage in injection drug use are at risk for a variety of needs, and SSPs can help PWID access and remain engaged in behavioral health care, address homelessness by navigating participants to emergency shelter, transitional housing, recovery housing, et cetera. And this is particularly true when an SSP is integrated directly into the homelessness and HUD-funded continuums of care. The access to supplemental security income or disability insurance and things like identity documentation, all of which can be barriers for people who inject drugs to access the resources they need. And SSPs can be seen as excellent programs to embed broad social service and case management engagement. And SSP can also work within the criminal justice system to help folks navigate parole and probation and to succeed if they're able to be engaged with drug courts or law enforcement assisted diversion programs. Any opportunity through which we can reduce the likelihood of a person who injects drugs engaged in services from experiencing harms or to increase their stability, SSPs offer an excellent platform to do so. And when talking through the difference between referrals and linkages of care, it's important that Syringe services programming attempts to do as warm handoff and deeply engaged services as possible. SSPs will need to work to maximize their impact on behalf of participants, but it's much better to do direct linkage to care work because an SSP has funded case management, navigation staff, community health workers, and folks who are able to help PWID navigate the significant barriers they face when accessing systems of care, whether it's lack of transportation, lack of income, the impacts of stigma and discrimination. And a passive referral does nothing to help participants address those barriers. By taking a proactive role in not only referring, but actually linking and helping to maintain a participant care, SSPs are able to improve not only their referral outcomes, but also participant health outcomes and quality of life. Oftentimes, how do we fund this? Oftentimes, SSPs are forced to rely on a core group of dedicated volunteers. They face chronic underfunding, and nearly all jurisdictions would benefit from more funding. There's a significant disparity in the funding between the largest and smallest Syringe services programs. Many of the early adopters in the 90s on the coast have much greater budgets than programs starting up in rural communities. And the average program runs between $250,000 and $1.5 million, but some SSPs run on less than $60,000, right? And it's largely through dedicated volunteer bases, which often are comprised of people who inject drugs themselves, that this is even possible. But if we're thinking about SSPs as being comprehensive and needing to offer a wide variety of dedicated services, it's going to be difficult for them to be as effective as they could be on such a small budget. CDC's estimated the cost of an ideal comprehensive SSP based on number of clients and geographical areas served. And it's important to note that these numbers assume a well-staffed SSP open 40 hours a week offering comprehensive services, and the cost is listed in thousands. So when you're looking at a small SSP, kind of the ideal here, as you can see, runs in the hundreds of thousands of dollars, with rural programs costing only slightly less than urban ones, in part because the cost for mobile units and personnel don't change based on whether or not you're in a rural base. But when we look at, and these programs are serving, a small program may be serving 250 unique clients a year, but medium programs, which the cost almost double for an ideal program, and large programs, which see them more than triple, might be serving 1,200 to 2,500 clients a year. These are targets, these three, right? And it's really important to acknowledge that while this might be the goal, when you have a jurisdiction that has no programming, it's really important that we get whatever we can up and running and over time work towards this. But at the end of the day, this is the kind of funding that we need if we want a program to serve participants the way that they deserve to be served. And we're lucky in that the federal funding has become available as of 2016. In the 2016 appropriation, notwithstanding the purpose of syringes, programs are now able to use federal dollars, assuming that they have consulted with the Centers for Disease Control and Prevention, done what's called a determination of need, and demonstrated that they are experiencing or at risk for a significant increase in hepatitis infections or an HIV outbreak due to injection drug use. The process through which they apply can be found in the Department of Health and Human Services implementation guidance to support certain components of syringe service programs 2016. And funding is currently available from the Department of Health and Human Services, the Centers for Disease Control and Prevention, Health Resources and Service Administration, and the Substance Abuse and Mental Health Services Administration through the Substance Abuse Prevention and Treatment Block Grants, the HIV grants, and the State Targeted Response to the Opioid Crisis grants, which is the funding that was passed last year in the 21st Century Cures Act. Funding is often available through major private funders, notably the Comer Family Foundation, the Elton John AIDS Foundation, the MAC AIDS Fund, North American Syringe Exchange Network, or NASN, and the Syringe Access Fund. And many programs also seek funding from local philanthropy, whether that's private foundations focused on substance abuse treatment, local HIV, AIDS, and viral hepatitis funders, funders of community health workers, funders of local homelessness services. But the reality is that syringe exchange programs, even extremely well-funded ones, cobble together funding from a variety of sources, and it's likely the case that any new program is going to need to be creative in how it seeks funding. And for jurisdictions who find they require support, the CDC, in partnership with a variety of community providers, offers free capacity building and technical assistance through the CRIS Express Suite. More information can be found at this link. And if you'll give me a moment, I'm going to pass this off to Christina Rodriguez from the California Department of Health, who's going to talk through what this looks like within a health department's comprehensive hepatitis C prevention and treatment program. Christine, it's all yours.
Hi, thank you. Appreciate it. Appreciate your time. You can advance to the first slide. All right, so we're just going to talk again really quickly about comprehensive Hep C prevention, a little bit about the context in California, about our projects here doing testing and linkage to care, and some opportunities for service integration for syringe services programs. Continue. And next. Next slide. Okay, so just a reminder, I think folks are pretty well aware of all this, but it's pretty important to remember how many opportunities there are for transmission during injection drug use, right? And so this doesn't even really have the sort of surface upon which you would be preparing your drugs. All of those things provide an opportunity, and so each of our sort of interventions that we have, syringe exchange, medication-assisted treatment, testing, and linkage, those are all necessary but insufficient for good Hep C prevention. Continue. So multi-component interventions are incredibly important. It's going to have to include health education on safer injection practices. Those are going to be really important. Provision of sterile injection equipment, very much including everything that folks are going to need if possible, much more than just sort of the needle and syringe, all the works, and medication-assisted drug treatment. And here the evidence that we have is really robust around methadone and around buprenorphine, and that can reduce Hep C risk by 75%. And so we have some mathematical modeling that's really great, right, that indicates if you add Hep C treatment to that, you can have a really pretty impactful an impact on the population prevalence and on incidence as well across the community. Next slide. So for folks who are interested in that modeling and in that data, it's pretty complicated. I find it complex. I would encourage you to check out the slide deck linked at the link below. If you have questions, there are some brilliant authors that you can reach out to. But the takeaway essentially is if you provide this combination of interventions, it shows you the impact that you can have in these localized epidemics across the country, whether it's just having medication-assisted treatment and syringe exchange, and what happens when you add different levels of treatment saturation through the community. Next slide. Similar to the slide before, this shows impact on incidence versus prevalence, and just what we would expect to see if you're able to provide these services in combination. Next slide. And just for folks' reference, they offered also a comparison of the settings to see sort of rural-urban, how much coverage of these services there are, and this is just so that y'all can maybe see what is most comparable to where you are in the country. Next. So here in California, we are a blue state that folks think of as extremely progressive around public health. I think that that is pretty true. And not all of California looks the same, right? It's an extremely large, extremely diverse state. We have 39 million folks here. And so while we have, great laws, great policies around syringe exchange, I think the coverage is extremely inadequate. You can see that all our counties with programs are essentially located along the coast. To be highlighted on this map, you only really have to have one program, and we know that one program is certainly not enough to handle an entire county. So just to have an idea of the coverage across our state. Next slide, please. Similarly, we unfortunately don't have a map like this that I know of yet that has our sort of buprenorphine coverage, but in terms of methadone programs, only about half the state has access, so half the state does not. And you can see a lot of these northern counties that don't have syringe exchange also don't have methadone programs, and half of the programs are in our urban areas around San Francisco, around LA, San Diego. Next slide, please. What we are extremely grateful for is that we have a very relatively permissive Medi-Cal treatment policy. It actively prioritizes active injection drug users based on a likelihood of transmission. A lot of community advocacy went into this, and so we have the privilege of being at least able to provide access in theory to folks who inject drugs. Of course, there's a lot of stigma, a lot of misinformation, a lot of education that still needs to go on to make sure that this policy is implemented as well and as broadly as it could be. But on paper, it is great, and we're trying to use this opportunity for our Hep C testing and linkage to care demonstration projects. Next slide, please. So as you can see, these are our rates of chronic hepatitis. You can see it's happening a lot in our northern counties. No surprise that that's also where we don't have syringe exchange and we don't have methadone programs, right? And this is not including our state prison cases, so we think it's more reflective of what's actually going on in the community. Next slide. And much like the rest of the country, we've also seen our new cases move from a unimodal to a bimodal distribution for chronic Hep C, and of course we think that's reflective of younger folks becoming newly infected, so primarily under 30. Next slide, please. Next slide, please. Okay, so getting to our testing and linkage to care projects, we have a really strong community advocacy network here in California, and in 2015 the legislature awarded the Department of Public Health $2.2 million a year for 3 years to administer grants focused on testing and linkage to care for Hep C. So we do this according to 3 goals. One is using surveillance to improve Hep C outcomes. That is just we have one site doing that. That's a local health department up in those northern counties in Butte County. And the rest of our sites are focused on testing and linkage and clinical care coordination. Next slide, please. This is where our sites exist across the state. We've got Butte County up in the top, covering San Luis Obispo and Monterey counties. We have Access Support Network, St. John's Well Child and Family Center, with subcontracting with Community Health Project of LA, a local syringe exchange, and Tarzana Treatment Centers, a broad sort of drug treatment and primary care network. And then we have Family Health Centers of San Diego. Of course, we are really excited also about our testing and linkage projects going on in San Francisco, and Paul will talk about that in a little bit in more detail. Next. So syringe services programs are involved in a bunch of different ways in our projects. The grant was purposefully written to be as flexible as possible to explore different models and see what might work better than others. GLIDE in San Francisco, Paul's going to talk about that in more detail. Urban community-based organization, fixed and mobile syringe exchange, and really doing a lot of testing, a lot of outreach, education, and linkage. And you can see how these other models are arranged. So we have a community-based organization doing a fixed site syringe exchange that's open with some limited hours in more rural counties. We've got a couple federally qualified health centers, so they're able to do a lot of linkage sort of in-house for all their services. But they have a sort of one-stop shop, particularly in San Diego. And in LA, we have a partnership between an FQHC and a local syringe exchange, primarily for linkage, and we're linking some of our most marginalized folks in that way. And you know, we can talk a little bit more about what that might look like. Next slide, please. And next slide. So, you know, I always want to acknowledge that, you know, we're incredibly lucky in California to be relatively well-resourced, even though we could always have more coverage and it could always be better. But there are always opportunities for integrating more services, even without a lot of resources, right? So the education and the training, I can't emphasize enough how important it is. There has been a lot of miseducation in the community around treatment. A lot of folks still think that we're in an era of interferon where the side effects are really, really damaging, really toxic, and it's important to spread the word in the community that it's not like that anymore, that it is much quicker, much easier to take, and only involves sort of oral pills and those sorts of things. It's really important to talk about how Hep C progresses, what folks might expect, and ways to prevent themselves from acquiring Hep C if they're negative, or preventing onward transmission. I also want to emphasize the importance of safer injection skills. We're seeing a lot of younger folks injecting drugs, right? And it's happening in the context where they are not shooting up with folks who have drug use histories, have experience around how to do it more as safely as possible. And we've heard that folks are increasingly also skipping, you know, the prescription drugs, skipping taking pills, and just moving directly to heroin. And so it's really important that folks are knowing how to shoot as safely as possible, because they're not getting that information in the community. Provider education has proved incredibly important. There's a lot of stigma out there, as you well know, a lack of cultural competency, particularly around perinatal services. There's an enormous amount of stigma, particularly for women who are pregnant and using drugs. And so it's incredibly important that women know, right, what makes sense for them while they're pregnant, what medically makes sense, and make sure that those providers are aware of that too. The doctors who are potentially treating may not have competency with this population, so it's really important to sort of gauge what's going on in your community, see who needs that education, and really make sure that you're directing your clients to the folks who are going to take care of them properly. Basic to syringe services, sterile injection supplies, hygiene kits are going to be really important. Unfortunately, here in California, we recently had a pretty devastating outbreak of hepatitis A, primarily among people who are homeless or using drugs, and that's absolutely a function of not having a hygienic space to live. So those things are going to be really important in terms of prevention for Hep A and other sort of, soft tissue infections and those sorts of things. Overdose prevention, education, naloxone training and distribution. Another sort of, syringe exchange classic. This is where we really have the competency and are going to get Narcan out to folks who most need it. And it's sometimes hard to engage folks around Hep C. It's asymptomatic and extremely long-term disease progression, and it's an excellent way of engaging folks and letting them know that you care about them sort of beyond the infectious disease aspect of the work, right? That it's really important that folks stay safe and stay alive. And then, of course, if you can either get screening into your programs or contract that out somehow with the health department, Hep C screening is going to be really important for folks to know what's going on with their bodies, right? We've seen that diagnostic testing is sometimes a challenge if you don't have phlebotomy in-house. And so that is just a pretty big linkage hurdle that folks should be aware of in advance. You still have to have the blood draw to confirm, and if you can't do it immediately, then you're going to lose a lot of folks that way. Next slide, please. So for sort of more robust programs that maybe are already starting to do screening or already have, and in areas, where you have treatment access even better, really linking folks to medical care. Referrals are important. If you're doing linkage, as easy as you can make it for folks is going to be best, right? And it's really important to link people to care even if you don't have Hep C treatment access open broadly yet. There are often many, many, many sort of primary care-related health issues that folks have that just need to be taken care of first, even if they were going to access Hep C treatment. And it can get them linked to sort of monitoring their stage of fibrosis and all of those sorts of things. As was mentioned earlier, syringe exchange programs are really where the expertise lies for care navigation, for case management, and this is really the crux of linkage, right? And navigation, like we talked about earlier, navigation is going to look a lot more robust with this population, right? When we talk about what navigation usually means to health systems, navigation is something that I need as a pretty health literate person who's able to navigate the healthcare system. I need a couple text messages to get me to an appointment, those are the things I need, and it needs to be much more intensive for folks with histories of incarceration, who are experiencing homelessness, places with no transportation, that sort of thing. For folks who don't have homes, et cetera, or really don't have safe places to keep their things, if you want to store medication on site, that can be extremely helpful. in places with treatment access, there are a lot of exciting sort of new models of treatment that are being explored. San Francisco, I think, is really leading a lot of community on this, whether you can do treatment on site at mental health facilities, at methadone programs, even considering the possibility of providing treatment at your syringe service programs. Those are all places where this could go. And then Hep A and B vaccination and testing and linkage to care is something to think about, because those are certainly co-occurring conditions that are going to exacerbate folks' Hep C and exacerbate that disease progression. Next slide. All right, so I'm basically done. These are a bunch of resources for you, for folks across the country, some free training opportunities and those sorts of things. And if you do have restricted treatment access, I would really encourage you to get connected to some of the local advocacy organizations doing that work at a national level. And yeah, thank you. My contact information is on the next slide, and I will leave it at that.
Thank you so much, Christine. And I just want to acknowledge again that we will be sending out the slide decks after the presentation, and you can always get in touch with us, Harm Reduction Coalition. Give me one moment, and we're going to pass it over to Paul Harkin from Glide, who's going to talk through what this looks like on the ground and within an actual program's capacity.
Hi, guys. Thank you, Kiefer and Christine. So yeah, I'm just going to follow up with what we're doing in San Francisco. I think there's been lots of excellent points made, and I'm going to focus on what it looks like on the ground. Okay, so the objectives here, we just want to, can you guys hear me? We want to increase knowledge of service. We want to understand that, when you have syringe service programs, these are magnets for a population, so it's really important that your population that you serve, you try and bring as many services as possible. So, if you think about old models of outreach where people go out and find folks, these are great, but when you already have something that people want, which is the syringes, they want the competent staff that know about injection practices, that you have a desirable entity, and folks are going to, come there. So what's the best place to have your services is right there, wraparound services at your syringe program. And we want to, the more that you integrate, the more you can do with that one touch when somebody comes in. So even if you don't have those services yourself, there's usually another agency that you can partner with. So for instance, we provide testing for other syringe programs that don't have testing. We've had people come in and do Hep A vaccinations at our site because we don't do that yet. We have sexually transmitted infectious disease. People coming in and doing testing at our site because we cannot provide that. So you have to look for very creative partnerships. Next slide, please. That's me. Next slide. So again, I think that I like the term the bridge to healthcare because people fixate on the syringe itself, and it's never ever really been about the syringe itself. Even if that was all we did, we would prevent so many infections, so many HIV infections, and so many hepatitis C infections. But it's all about dignified, non-judgmental engagement with people that links them to so many other things. And we want to always be adding what we can do, whatever the funding is. You've got to squeeze everything you can out of every last dollar. And at Glide, we were funded for testing, and we were funded for syringe access, and we kind of, we made that into outreach, we made that into roving exchange, we just, because it's all about the outreach to bring people into your program first and foremost. Next slide, please. So yeah, what we're talking about today, and you've heard so much about it, so it's really, having competent staff, very important to utilize peers, people who understand the life of injection drug users, who've maybe been there and done it, maybe still are doing it, but they are competent and they're able to have conversations, like what Christine was talking about, lots of injectors need support and safer practices on how to inject. So you can have things like what we do is we have slideshows that show people things, or we also have, former injectors that show people how to hit a vein. and have discussions about healthier ways of utilizing their injection. So many different names, syringe service programs. I think that one tries to encapsulate that it's not just about syringe distribution, access and disposal. Next slide, please. So we've already heard the data, so let's just skip on. Let's just say Hep C is, as we know, injectors make up the vast bulk of folks with Hep C. And if we can get into that population, like we're trying to do in San Francisco with our End Hep C campaign, and get people treated now that active injectors are a priority population, what we're seeing now is we can really talk about, taking the community viral load down to a level where it's going to be hard for people to get infected because so few folks will be infectious. So, I mean, this is a real goal. Obviously, we need the funds to back up but the way that we've looked at this in San Francisco, because we've built up over the top of an incredible community-based HIV programming, we've added Hep C to that, and we have really excellent access. We just need more funding to make sure that more people get access to treatment. Next slide, please. So yeah, again, you've already heard the data, so I'm not going to dwell on that. So just let's go on to the next slide. Just for people who don't know, this is it's very important. Those of us who do know, we take it for granted. But when you step outside that harm reduction, bubble, a lot of people don't realize that syringe programs go way back to the 80s. America was a little bit of a late adopter. There's very kind of puritanical, there's a lot of contempt for drug users, and it took AIDS to be devastating in cities like San Francisco and New York, and the community itself started to do syringe programs. So you'll often hear health departments taking credit, but this was a community-driven intervention. It was drug users that were looking out for other drug users, and people got arrested to do syringe access. So anytime I'm talking about this, I always want to remind folks that this comes from the community, and it has become one of the most effective public health interventions that's ever been, put out there. Next slide, please. So yeah, our program is basically we have a fixed site. During the day, people can drop in. And while they drop in, there's always HIV testing, hepatitis C testing, HIV navigation, and hepatitis C navigation folks here. So, when somebody's ready, you want to be ready for them. So we don't, like what you heard, there's no pressure. It's just about letting folks know. We did a huge campaign around the new treatments for hepatitis C. And of course, so that was things like all our staff were wearing T-shirts that said new treatments have changed the game. We had posters, we had flyers for outreach, and it was really, a very concerted effort to make sure that the community understood what was going on. And it was, we know from our own data that it was highly successful because in every Hep C test that we do, and we do about 125 Hep C tests a month, we ask the client, have you heard of new treatments? And when we first started this about 3 years ago, when we were a pilot before the demonstration project, it was about 95 out of 100 said no, maybe even more actually. And now it's down to about maybe only 10 out of 100 that say they haven't heard of new treatment. So in 2 years, that's been an incredibly effective campaign, and that's crucial for whatever jurisdiction you're working in, is to make sure that folks understand, because the people, especially the older folks that remember interferon and the horror of that toxic treatment, they're just not going, they're going to tune out when you start talking treatment unless you, so hence new treatments have changed the game. Next slide, please. Syringe access or syringe service providers, it's really, this is a place where drug users should always feel at home. So as was said earlier, if you're doing one-for-one, just there's no evidence, it's actually harmful. The evidence shows it's harmful. You have to rethink that immediately. That's just, extremely foolish policy, and it's not. You're not going to have the same kind of credibility when you provide needs-based services. And if you're a DPH group who's running it, you really want to involve community programs because they have the cultural capital with that population. And just to, one of the things is the Department of Public Health can often seem very official, and it can, for folks who are coming from marginalized populations that are used to stigma, criminalization, etc., they often don't want to be having to do with the Department of Public Health. So, you know, having syringe programs has really been a bridge to a lot. That's some people's only source of healthcare. So if you have nurses that come in maybe once a week and things like that, you can make great inroads in improving the health and well-being of drug users. Next slide, please. So, yeah, so, I mean, GLIDE is very much an integrated program. And just for folks who maybe are building a program, you know, it doesn't just happen overnight. It just came from gathering some different funding streams. But the fundamentals were having outreach to make sure the program was utilized. I can't stress that enough. Like, you can have fantastic services located in a beautiful building, but if the people don't come, you cannot deliver the services. So, you know, even though you don't get funded for outreach, if you've got a tester who's sitting in an office waiting for somebody to test, and they're there 8 hours a day, and only 2 times a day does someone walk in to test, then why not make that tester an outreach worker half a day, reduce your testing time, and then bring more people in from the 1 o'clock to the 5 o'clock shift or whatever you want to do. It's all about utilizing the talent, making sure people are doing things rather than sitting around waiting for clients. So, you know, outreach for me was crucial in building the profile of the program, and it also, you know, it got other funding because the program became very, very busy with people coming in because the promotion had been highly successful. So, you know, you want to always have HIV and hepatitis C testing offered together. I mean, in every jurisdiction that you have those trainings, it's usually only about 4 hours more for a HIV tester to become a hepatitis C tester. So anybody who has HIV testing at their syringe program, or someone who's coming in and providing that, it's so easy to also add Hep C. So strongly, you must, you know, add Hep C testing if you're already doing HIV. And if you're not doing either, then you should be doing it, because the sites are great places for people because it's super convenient and they're already coming there. So, you know, and usually the staff at a syringe program are seen as allies. So people are more likely to uptake in testing versus going to Department of Public Health clinics or STI clinics. So next slide, please. So, you know, having linkage to care, can't stress it enough. I think, you know, Christine talked about it and Kiefer. You know, passive referrals are just not very effective with this population. So, you know, when you have somebody, they're basically like, they're going to act like a buddy. You know, they go and find the person. If they're in a homeless encampment, you know, they follow up with them. They take them to their appointments. You know, you know, we might even incentivize navigation visits so that they can come in once a month and they have $10 when they get a $10 gift card. Now the point for that is we want continuity of service, and people have competing needs. They might not come in. So even if you have fabulous, charismatic staff, you still might need to drop a little $10 gift card on someone just so that they make a little mark on their mental calendar. And you know, we've had great success with folks that you know, have a lot of competing needs. So you know, it's very cost effective versus having somebody running around looking for a client if they're coming in and making their appointment for a simple $10 gift card. I mean, think about the efficiency of that. So that's something that's important. And then just clients that know the system, you know, so folks who maybe have had Hep C treatment or are on HIV meds, they've been through it. You know, you want very informed navigators. And then from the navigator, they're a face of your agency as an ally, and they can be the bridge to programs. So they should know which programs, you know, which providers are culturally competent with trans folks, with African American folks, with injection drug users, with crystal meth users, with crack smokers. You know, you as a navigator, you know who works well with what population, and you just, you know, you help working with the client and tell them who you think would be the best fit. But obviously you help the client really drives the intervention, but you support them by giving them the information to help them make the best choice possible. And that's crucial, because if you set somebody up with a provider that, you know, talks to a trans woman like she's a cis female, it causes all kinds of problems. They lose complete faith in the provider. You know, and these things happen even in San Francisco. So it's very important that you are constantly getting feedback from your clients. Next slide, please. You know, I said it earlier, the street-based outreach, wherever you are, you've got to have some outreach going on. So, you know, again, I've used the model. You think about somebody sitting in an office and they're a tester and nobody comes in. You just put 8 hours in the trash can. Why are they not out engaging people and bringing them back for testing? It just makes so much sense to me. I can't believe that more people are not, actively using outreach to bring people into services. You can also do outreach in venues, so for instance, we know that there's a lot of folks who are at high risk in adult shelters. So the adult shelter system does not have HIV, Hep C testing or navigation or linkages. They might have some case managers. So we go there once a week or once every other week, and we bring our team and we provide those services there. So, now you got an in with a partner and you got access to the high-risk population. And because the window's shorter, so we go there for 2 hours, we'll test 7 people, say. So that's 7 people that if you were sitting in your office that you were not getting, and they're, high-risk people that you're screening in. So utilizing adult shelters, navigation centers, homeless meals programs, these are places that those folks are usually very willing partners. So, you can go to a food program and say, hey, while you're serving lunch, can we do testing in a room over here? And you can add testing. So, we also do a syringe program. We always do syringe distribution and collection while we're doing these outreach things, so that folks have easy access. So somebody might just come up for syringes because they know you're doing that, or smoking kits. But you start having a conversation, turns out they tell you, yeah, I've got Hep C, man, I don't need to test. Next minute that becomes a navigation conversation. So, that's why you want to have navigators like Chris Stevenson. You want your phlebotomist cross-trained. So the guy who's testing will also be a syringe worker, will also be a phlebotomist, and will also be a tester, ideally. So that you can get, with one touch, you can offer so many services. So to cross-train your staff, it makes great sense for when you're talking about trying to get the best value for your dollar, okay? So, I think people who have the capacity to go into other venues, you will reap the rewards because you build up community relationships. Your program gets more recognition because these homeless folks are seeing you at a meals program. They're seeing you in a shelter. They're seeing you in a low-income hotel. So that they start to realize that you really are there for them in so many convenient spaces that they inhabit. And you become it gives you really, rich cultural capital for those folks to trust you and to utilize your services. Next slide. Obviously, substance use treatment, we do not provide that. We're currently working on trying to have, a couple of times a week, because one of our partner programs over at 6th Street, Terry Morris's Harm Reduction Centre, they've been doing, offering people Suboxone, and they have lockers for folks to keep their medications, and that's definitely an innovation that we would like to adopt here at Glide. But sometimes the machine moves a little slowly, but that's definitely an aspirational goal to add, versus, and we will take people right over to, the treatment access program. So, and that can be walking over with someone so you can converse. That can also mean taking someone over in an Uber when they're ready to go. So having navigators that are going to link people to treatment is an awesome, awesome component, because you know how it is with some folks. They get in a situation where right now that's something that they want, but that moment might fade. And so if you can offer immediate support and take them to the treatment programs and get them on Suboxone, that's a beautiful thing, And again, it's a capacity issue. If you can't, then you want to partner with those programs, and maybe they come and pick people up. Next slide, please. So yeah, just like something that we should always remember to tell folks, because people talk about the needle giveaway. It really freaks me out when people are so dismissive and don't understand anything about the immense, other work that takes place. And you can see, I think this is a Don DeJarle slide from Beth Israel survey, just showed you that, so many programs offer at least Hep C testing, HIV, and referrals to treatment. And that'd be a good minimum. I think that's the minimum that folks should have. And again, if you cannot provide that by yourself, then you want to bring a partner in who does do testing and have them provide it. Next slide, please. Obviously, we have the greatest access to the people who are at risk for overdose. So it's mind-bogglingly crazy if people who have a syringe program are not doing drug overdose prevention education. I mean, it's egregious, and again, it could be resource, but there's so many ways to get naloxone, you know, and train people how to use it, that, you know, any program has to include this. It's just like, you know, we're talking about, you know, in the midst of this epidemic of overdoses, you know, it's on us as providers of syringes to be making sure that we're educating people and we're helping them gain access. So folks that don't have that, they should definitely be getting in touch with Eliza Wheeler from the DOPE Project, or going through a Harm Reduction Coalition and finding out if there's a way that they can have naloxone at their program, because, you know, there's nothing better than drug users saving other drug users' lives. That's what they want, that's what they need, and that's what we have to provide. And it only takes about 6 minutes or 7 minutes to train someone on how to administer naloxone. So we do that during outreach. You know, so we'll be out in the Civic Centre. There's like maybe 30 people injecting drugs in front of the Asian Art Museum, and we're just going to kneel down, talk to them, and start doing overdose prevention training, you know, right there and then. It's the training for folks, and people, the uptake in San Francisco has been incredible, and that's why we have like quite a low number of overdoses compared to other parts of the country, because our network of syringe programs have been doing overdose prevention education trainings since the 2000s. So I think, you know, we really have a very educated and capable drug user community that cares for itself. And anytime the drug user community is caring for itself and it might need some assistance for us, like providing the tools, which is the naloxone or the training, then we've got to get on board and support that, because, you know, that's something that to cherish, is the way that people look out for each other. Next slide, please. Yeah, I mean, it's just, you know, it's so obvious, right? If you have syringe programs, then you have to have overdose prevention programs, you know, like integrated. It's, you know, we're at a time of like catastrophic death, and it's, you know, it breaks my heart when I hear about programs that have problems getting access to naloxone. Can I have the next slide, please? Yeah, so just, I like this little quote. You know, the evidence, you know, just like we're currently having conversations around safer consumption, and it's very important that we remember that when syringe programs began, they were seen as controversial. People said they were enabling, all the usual kind of, you know, flawed arguments that the evidence is completely obliterated. And, you know, we need to remember that, you know, while we have syringe access, we want to get to the next level of intervention, which is safe consumption spaces. But, you know, what can you say other than acknowledge how successful that syringe access programs have been? Just incredible success. The volume of people's lives that we've saved, the people who have been linked to other services, from primary care to Hep C treatment to HIV treatment. Just incredible work that's been done by often a lot of underground syringe programs, you know, just done this incredible work. So let's be proud of our successes and let's build on them. Next slide, please. Yeah, so you can see even prestigious people have spoke up in praise of syringe programs. Next slide, please. Yeah, I just want to emphasize, and I think, you know, Kiefer and Christine talked about it earlier, even programs that are not sanctioned, you know, these are programs that need to be supported. If folks have a testing program and there's an unsanctioned syringe program, then maybe they want to partner with that and use their population, you know, utilize it, offer them the testing service. It's all about creative partnerships. You know, that's the reason that GLIDE's program became successful, was by forging, you know, numerous partnerships at the intersections of where our populations, you know, were also going. So whether that was low-income hotels, whether that was people coming out of jails, you know, we've partnered with as many people as possible to increase the opportunities for those touches. Next slide, please. I think you saw some nice maps earlier. You know, it's really obvious that when you don't have drug treatment and when you don't have syringe programs, you have high rates of Hep C, you have high rates of HIV, you have high overdoses. So, I mean, it's a no-brainer to understand that syringe access, syringe service programs are, you know, can be utilized in so multiple levels and so many jurisdictions, because we know that injectors exist in all of these jurisdictions, and it's, it's a public health neglect, egregious neglect when you don't have syringe programs for folks in states that have moral objections versus public health science, because there's so many benefits. And again, DPHs should always be partnering with the CBOs that do the work. Should be supporting CBOs that do the work, helping them add on other services. It's just, CBOs, again, they have the credibility, they have the community, they are the community. So utilize CBOs, please. Next slide. The cost effectiveness is, being emphatically proved. There's a bunch of studies that have showed it, and I think we heard it earlier. And if you just think about even Hep C treatment, how cost effective that's going to be. There's an estimate that an injector might infect 18 others, so in the course of their life. So if you think about 18 infections averted alone by treating one person, you can see there's so many models that show the cost effectiveness. Can I have the next slide? Right. So Christine touched on this earlier. When we talk about health disparities, right, which we really mean is, systemic racism. Like, health disparities is a much more pleasant term, more palatable. Like, they just fell from the sky, when in fact there are systems that are discriminatory. So, SAS programs have had great success in helping to reduce those inequities, because they are the community providing services for the community. They don't have the baggage of, or the best ones don't have the baggage of, systemic racism. So it's again, another very crucial linkage to populations that have medical distrust, and I think Christine touched on that. So it's super important that you really utilize peer involvement and have truly representative workers, culturally competent workers, to increase the opportunities for reducing health inequity. Can I have the next slide, please? Just by the way, there's been some nice posters on the side there that came from our campaign. So, there is new hope for people with Hep C or living with Hep C. New treatments have changed the game. They've been popping up on the side, I should have mentioned. And that was a campaign that was adopted by Glide, and then it got taken up by other providers in the city. And I think it's been a very successful campaign. So, launched really through our syringe program and our testing coming together and creating this new messaging and using drug user language, drug user focus groups to come up with very basic, simple statements that were non-judgy, because that's crucial. But again, just the disparities of both HIV and hepatitis C are unacceptable, and we all can do better. So I think we have to, when we talk about the war on drugs, we're always talking about racism, and we've got to dismantle racism as well as the war on drugs. In fact, as people have argued, racism first, because you can't dismantle the war on drugs without dismantling racism. Next slide, please. So just a quick summation here. Syringe service programs, incredibly effective at bridging people who inject drugs and the other, makes them feel safe, makes them feel not judged. They have time to reflect on their behaviours, and if they want to adopt any behavioural change, you have culturally competent counsellors who are there to support them. You can, wherever they're at, you can be reducing harm even if they continue to use. It's ideal setting. When you have a syringe program, you should have testing. Just whatever way, whatever means necessary, get testing, even if it's just once a week. So you tell everybody who's dropping in that every Tuesday we will have HIV and Hep C testing. Just start somewhere and start building that up. Again, we have a roving exchange, because you don't just wait for folks to come to you. You want to be out into the community. The ability to provide navigation. So many injectors are coming in and telling you they already got HIV or Hep C. It's like, but they're out of care because they've had bad experiences or whatever else is happening in their life. And when you start to offer the navigation from your syringe program, the chances of that person following through are really high, because you have that relationship. You are the community with them, and you can help take them through and navigate, like what Christine was saying. It's not like just a text message. It's often, doing some medical translation, going with them to appointments, talking them through whatever medications they're taking, supporting them in many different ways that will improve those outcomes. That when you have the access that syringe programs provide to the high-risk groups is very important to, bring in other services, right? I mean, just giving people syringes, if that's all you can do, you're reducing disease, and, you're doing great, but there's so many other things, and you might need support or partnerships to add those other things. And it's very important that, your program vision is adding those other things, like at least HIV testing, at least Hep C testing, and hopefully navigation, because that population will need extra support to follow through on the medical side or the treatment side. Again, harm reduction programs, it's not abstinence based, but abstinence is certainly a part of harm reduction, and we've linked many folks to drug treatment programs that are abstinence based, but we've also supported people in other harm reduction modalities. But the connection to treatment is crucial, and again, when you're bringing people there in non-coercive ways, when they're ready, that's another awesome component of a good syringe program. The evidence is long in, and it's cost effective, so that can help you sometimes if you have NIMBYs and you're trying to argue. We hate to go from the humanity of our intervention and talk about the fiscal, propriety of it and its success, but you have to use all the arguments and all the tools on your side occasionally. Okay, can I get the next slide? Okay, I'm done. Thank you, folks.
All right, yeah, so at this point, we've got about 15 minutes left. I want to make space for any questions y'all might have for our wonderful panelists here. All right, well, hearing none, we will be sharing our slide decks with folks, and you can always find additional resources at the Harm Reduction Coalition website, as well as, again, the CDC offers technical assistance and capacity building programs for health departments and CBOs through health departments that are serving people at risk for HIV and hepatitis C. We appreciate y'all coming out to join us, and I think we'll wrap it up early.
Thank you, folks.